Okay, everyone, it is 9 o'clock, so we will go ahead and get started. I want to welcome you all to the first in our winter webinar series for those of you in early intervention who are participating in the early intervention training programs webinars. Thank you so much. Today we will be looking at advances in genetic testing for autism spectrum disorders, what early interventionists and families need to know. Our presenter today is Dr. Cesar Ochoa, who is the head of the developmental behavioral pediatrics. Sorry, apparently I can't talk today. And he is a board-certified developmental behavioral pediatrician. He is also an associate professor and division chief of developmental behavioral pediatrics at Rush University Medical Center, and the medical director of Rush Neurobehavioral Center as well. He has established a multidisciplinary developmental behavioral pediatrics clinical program at Rush that evaluates and provides specialized follow-up care, including psychopharmacological management to children and adolescents with ADHD, autism, Down syndrome, Angelman syndrome, and other complex neurodevelopmental conditions. He is also the clinical leader for Rush ADHD Quality Improvement Initiative grant, which is sponsored by the American Academy of Pediatrics and Cesar. He runs the Pediatrics ADHD series with ECHO Chicago, which is through the University of Chicago. He's been an investigator in clinical trials for autism disorders, Angelman syndrome, Down syndrome, and Fragile X. He is an elected member of the Illinois chapter of the American Academy of Pediatrics and is on the executive committee and co-chair of the ICAP's Child Development Committee, and is also a medical consultant for CSC 11. So, Dr. Ochoa, thank you very much for joining us, and we look forward to hearing your presentation today. And just some disclosures, he has received some funding from the organizations that you see on your slide there, and thanks for sharing that. Today, the moderators for today, myself, Maria Maddox, I'm there on the top, and Alyssa Jones is also joining us, and Alyssa is no longer the visiting project coordinator, and I shouldn't have even brought that up because she's got a new title, and it's blocking my memory now what exactly it is. So Alyssa, if you could type that into the chat box, I would so greatly appreciate it. Alyssa is Instructional Design and Technology Coordinator. Thank you so much. We'll be here helping behind the scenes, so if any of you have any issues, feel free to chat that to us. If you participated in webinars by the EI training program before, you kind of know how this works, but if not, let me tell you a little bit. So at the end of the webinar, probably around this afternoon, like, I don't know, 2 o'clock-ish or something, you're going to get a survey from the training program, and in that survey is the, you complete the survey. Once you complete that survey, you will get an email with your certificate of attendance. So just remember that if you joined as a group, you would have needed to have each individual register in order to get that unique email from the training program to get your certificate of attendance. So. Also, as we've been talking, my goodness, I mean, webinars are awesome, and what a day like today where if you didn't have to go anywhere, then and are able to stay at home, awesome, or Starbucks. But one of the downsides to webinars is you can't see us and we can't see you, and so participation can get a little confusing since we can't really see each other. So we've got a couple of tools that we're going to use today to help us keep us all engaged. And the first is the chat box. So many of you have found the chat box. Let me find my pointer here. It is in the left side of your screen. And use your chat box to type any questions that you may have. And in fact, let me just say now, if you have a question during the presentation, just type it in. We may not address it right at the moment that you type it in because we have built-in question breaks throughout the webinar, but get it there. That way when we get to those breaks, we'll have a question ready to go. Also, please share in the chat box any comments or strategies that you have experienced, anything that you just would share in a regular face-to-face training. Just feel free to type it up there in the chat box. And we will be addressing questions during question breaks, but feel free to type those in whenever they come to your mind. Also, there are a couple of other ways that we might engage each other in this webinar. And if you look on your left-hand side of your screen, under your name, so you should have your, say, participants and then name, and you'll see the first box there is a box that you can open up an emoticon and add little emoticons next to your name. Let us know if you're, having a great day. You'll see I did that myself here. The third box is a hand raise box. And we'll use this ever so often, like we might ask the question, how many of you are sitting in Starbucks today? And you can raise your hand and let us know how many of you are there. And then you push it once and it goes up, and you push it down again and it lowers your hand. The fourth box is a polling function, and so throughout the webinar we have a few polling questions to kind of get an idea of an understanding of the topic and things like that. So we're going to start with our very first polling question, and it's that fourth box under your name. And so our question is, who do we have participating with us today? So if you go to that fourth box under your name, right now there's a letter A in it. If you open it up, you should be able to select what your particular role is. And we'll give folks a few minutes to do that so that they can find it. And if it's not, if you're not listed there, we only have an option of 5, so we can't list everybody. But go ahead and put your other in the chat box, and we see that Hattie's parent liaison. We've got Sarah as a licensed clinical social worker, and Bethany is an SLPA, RN. Awesome. Okay, we've got some other folks in here. All right, we'll give folks a few more minutes to find those. I see some more responses coming in. All right. Let's go ahead and post those results. And thank you, Alyssa. So it looks like we've got about a quarter of our participants are CFC staff. And then we've got a good mix of PT, OTs, speech, DTs, a lot of others that I've listed in the chat box. So this is our audience for today. Welcome, everyone. We're so excited for you to be here with us today. Let's see here. I believe that at this point in time, I'm going to turn it over to Dr. Ochoa, and if you're ready, we will go ahead and get started.
Thank you, Maria. Can you hear me well?
I can hear you just fine.
Well, thank you very much for a nice introduction. I'm very excited to be in this webinar and share the genetics of autism with the early intervention community. I think early intervention is a great program, and the work you do with young children is really important and makes a difference for the children and for the families. So I look forward to an exchange of ideas. Please feel free to let us know if you have any questions, and I would be glad to try to answer them. So the objectives of this presentation are discussing the biological basis of autism, reviewing the clinical presentation, diagnosis, and treatment of autism. So we're going to go a little rapidly through this because, that's not the main purpose of this presentation. We're going to talk about the genetic testing that clinicians order for autism and other neurodevelopmental disorders. We're going to talk a little bit about what are the mechanisms that cause autism and what is going on at this time in genetics, research in the genetics of autism. And we're going to talk about what's the significance and the benefits of doing genetic testing in individuals that have autism. So do I have the control, Maria, to move the slides?
Yes, it's the top button, the forward and backward buttons at the top of the whiteboard.
Okay, I got it. So let's start with a question. What do people think about, what do you think is the prevalence of autism in the United States today? If you can all try to answer.
Right, so in your, again, it's that polling function, the fourth box under your name. Go ahead and pick what you think is the prevalence for autism spectrum disorders today. We'll give folks a few seconds to use the polling function, if you would, please. Click that fourth box under your name, and right now it should have a letter A in it. If you click on it, it opens up to A, B, C, D, or E for you to choose. Okay, we'll give folks a few minutes to find that. All right. All right, let's go ahead and post those results and see what we've got. So it looks like the majority of folks chose option C, 1 in 68. What do you think, Doc?
Let's go to the next slide. So the prevalence of autism has increased significantly since now there's a program through the CDC that does active surveillance in 11 cities in the U.S. And the reports from that surveillance has led to increasing numbers in terms of the prevalence of autism. So the last number that we have available from the CDC is 1 in 59, which is somewhere between 1.5 and 2% of the American population has a diagnosis of autism. So this is an increasing prevalence over the years, and people wonder what's going on. Is this really increasing, or are we? So the explanation from epidemiologists is, for the most part, this increase in the prevalence of autism has to do with an increase in identification of children. Like there's more awareness about autism in the community. In the community, parents are more alert about communication delays, social communication deficits, and clinicians also have become more aware. Also, there are more teams that have expertise in diagnosing autism, and an important factor for this increase in prevalence is the fact that the spectrum has widened. There are many children that have milder social communication deficits that are highly verbal, that meet criteria for autism. Those are like kids that have high-functioning autism that were not diagnosed before, but now they have a diagnosis. And also, there are a number of children that have significant developmental delays that in the past they were diagnosed as having intellectual disabilities, but now they are, they are evaluated, and you can find in some of them a diagnosis of autism. But it's still, even with these explanations, it's intriguing the increase in the prevalence. There are some studies in England when they have like more government health systems, that everybody has the same health system, that they have found doing studies looking back into all patients, older patients, they found like high prevalences of autism. So this is not something totally new. This is something that, this evidence from the England system points that this is not something new, that the high prevalence of autism has been present, but it was not identified as much. So I'll move to the next slide. So what is autism? Autism is a heterogeneous neurodevelopmental disorder that is characterized by two sets of symptoms. on one hand, we have impaired social interactions, and on the other hand, we have restricted repetitive behaviors and interests. So to have autism is not enough to have impaired social interactions or just have restricted patterns of interest and behavior. You gotta have both, and they both need to be significant in the functioning of that individual. And that is the definition from the American Psychiatry Association in 2013. That's DSM-5, which is the DSM that we're following at this time. So the understanding of autism is that it results from early altered brain development and neural, like the conduction between neurons, the connections between neurons that are not well organized. Unfortunately, we don't have reliable biomarkers. We don't have a test that we can do and we can say, okay, this test is positive, we have a diagnosis of autism. Still, the diagnosis of autism is behavioral, and we'll talk a little bit more about that in the next slides. And so that's about autism. So now we're going to talk a little bit about the biologic evidence supporting autism. And one of the key findings when you look at the biological evidence of autism is the wiring. So the evidence shows that, you know, unlike typically developing individuals with autism have a decreased overall brain connectivity. A little bit like individuals with intellectual disabilities. But the difference between individuals that have intellectual disabilities and individuals that have autism is that there's an over-connection at the local level. And maybe this could explain the fact that sometimes they over-fixate in details, but this is a significant difference. Overall decreased connectivity with increased local connectivity. And this is a busy slide, but I really like it because it shows the current understanding of different lines of evidence supporting the biological basis of autism. So the best known findings in autism, and are more consistent, is the fact that the young people with autism have overall, they have accelerated brain growth. And this is from autopsies and also imaging studies like MRIs. So the young children have larger brains, but then over time they seem to, be more like typical size. The other evidence is that there's the cortex, the brain cortex is more disorganized in individuals with autism, and that's something that has been found, in autopsies, like looking into the kind of tissue that is in the brain, in the cortex. At the systems level, this is what I just mentioned before in the slide before. There is a decreased overall connectivity in the brain of individuals with autism. The other important concept is we have neurotransmitters, which are the chemical substances that facilitate the communication between neurons. And we all have excitatory neurotransmitters, and we also have inhibitory neurotransmitters. And we have a balance, for the most part, between excitatory and inhibitory neurotransmitters. And it appears like individuals with autism have a predominance of excitatory neurotransmitters. And these are the genes that mediate that increased excitatory neurotransmission. And that happens also in individuals with Fragile X or individuals with other syndromes. One syndrome when this is opposite, where there is a predominance of the inhibitory neurotransmitters, is Down syndrome, which is a little bit different. Also, something that we're going to be talking more during this presentation is there are many genes that have been associated with autism. There are hundreds of genes that have been associated with autism. There's no one gene that explains more than 1% or 2% of the cases of autism. But something that researchers are figuring out is that apparently these many genes, they have some common paths that lead to the changes in the brain that are going to lead to what we see in autism. So some of those common paths are there are a number of genes that affect the protein synthesis or the neurons' activity or the adhesion between neurons. So I'm going to go back and do a brief review, talk a little bit about the history of autism. So autism was described first in 1943, 1944, and we had, at that time, that early, we had two types of autism. We had the Kanner type of autism, which, you know, just to illustrate, is more like the Rainman type of autism. Individuals that don't talk too much, that are very shy, very withdrawn, with a lot of restricted repetitive behaviors and interests. And then we have the Asperger type of autism, with individuals that are highly verbal, that seem to talk on time, and that can be outgoing, but have significant restricted patterns of interest and behavior. And also, even though they can be really smart, they don't get the reciprocity of social interactions. So what we see in autism now in 2019 is the same that was described by Kanner and Asperger's. We still see that there are deficits in social connectedness and an increase in restricted patterns of interest and behavior. But the way it is conceptualized by the American Psychiatry Association, which is represented by the DSM classifications, has changed over time. Like in the 50s, people were thinking, in the 50s and 60s, people were associating autism and schizophrenia, which, you know, we know nowadays that individuals with autism are different than individuals with schizophrenia. And so we don't have that confusion anymore. We know now that autism is very different than schizophrenia. Now, there are a few very rare kids that can present a little bit like autism, and eventually they develop into a picture of schizophrenia, a clinical picture of schizophrenia. Something that started coming up in the late 70s with DSM-3, is that the broader autism spectrum, because in the past, autism was associated with very significant deficits. These were individuals that had very limited functioning. And in the late 70s and 80s, people realized that there are some individuals with autism that have milder presentations, that can be really smart and can have relatively good levels of functioning at school and in the community. And then we have DSM-4, which came in 1994, that brought the concept of Asperger's syndrome. And the concept of Asperger's syndrome was really important because it helped people understand the high-functioning autism presentation. Unfortunately, Asperger's syndrome is not like it was not a scientifically defined, scientifically useful classification. So now we have DSM-5, and I'm going to go to the next slide. So, you know, there's so much. Autism spectrum disorders are so heterogeneous. They can be so, you see one individual with autism and is, you know, like a Rainman type of autism with classic autism. And then on the other hand, you see a kid with a mild, high-functioning form of autism, and they look so different. And then you wonder, is this the same diagnosis? Because these kids look so different. But they both meet the current definition for DSM-5 in that they have a different social connectedness, and they also have restricted repetitive behaviors and interests. We do know that there might be subtypes of autism, but we don't have enough knowledge to do this categorization of autism. So this is something that is probably going to come in the next years with more research. But at this time, the scientific community has acknowledged that we don't know enough about autism to come up with classifications, and that the prior classifications like Asperger's disorder and PDD were not scientific valid, and it was not good for research to continue using classifications that don't have scientific validity, because that's not going to help move forward in the understanding of autism. So at this time, what we do is we define autism spectrum disorder based on high level or high functioning, High functioning is defined by having an IQ that is in the normal range, and then you can also say autism is mild, moderate, or severe, depending on the severity of the symptoms. You can also use the language level to describe better the presentation of a particular individual. So this is something that we've been talking about. These are the criteria from DSM-4. For DSM-4, you have to have four criteria for communication, 4 criteria for social interaction, and 4 criteria for restrictive and repetitive behaviors. And you needed to have 6 out of those 12 to meet criteria, and at least 2 of them have to come from social interaction. So with DSM-4, you didn't need to have restrictive and repetitive behaviors and interests to meet criteria for autism. So now with DSM-5, it's simplified, because one of the key concepts of DSM-5 as opposed to DSM-4 is, there are a lot of people that have autism and they don't have communication delays. And you in early intervention know that there are a lot of kids out there that have communication delays and don't have autism. So really communication is not a good criteria for autism. What really matters is the functional use of communication, wherever their communication level is. So there are some kids that have communication delays, and if they cannot have a good functional use of their limited communication, then that meets criteria for social communication deficits. And then also if there are individuals that have advanced communication skills, but they may not be able to use those advanced communication skills. So these social communication deficits, there are 3 criteria for social communication deficits, and in order to meet these criteria, they need to hit the three items: the different social connectedness. There's a deficit in nonverbal communication for social purposes like eye contact, use of gestures, and also there's a third, which is not having appropriate relationships to their developmental level. So that's the social communication, and the 3 criteria must be met. But there are a lot of kids out there that do have the social communication deficits, but that doesn't make a kid to have autism. The big difference between DSM-4 and DSM-5 is that you must have, in addition to the social communication deficits, you must have restricted repetitive behaviors and interests. And there are 4 categories, 4 items for restricted repetitive behaviors and interests, and 2 of those 4 need to be met. So one is kids fixate in specific topics of interest in a degree that is excessive for developmental level, because the people that have kids or have worked with kids, we know that toddlers can get very fixated with some things and they want to play with that, but that can be very typical for their age. But when this interest exceeds what you would expect for a kid that age, then that's considered positive. The second restricted repetitive behavior and interest item is individuals with autism have insistence for sameness. Once they figure out how to do something, they want to keep doing it the same. They have unusual routines, and they have a hard time with change and transitions. So that's something that's a second criteria. There's a third criteria where you have 2 things. On one hand, you can have the motor mannerisms, the arm flapping, excessive perseverative rocking, hand mannerisms, or you can also have echolalia that is beyond what you would expect for, there are some kids that when they are learning to talk, they do some echolalia, but in autism is in excess of what typically developing kids do, and or sometimes they use a lot of scripted phrases. So one of those 2 items, the echolalia or scripted phrases or the motor mannerisms, can meet the criteria. And then the 4th item for this set of criteria is unusual sensory interests, when kids are spinning over and over the wheels of a car, or when kids are looking at objects really close and from different angles in a way that is excessive for their developmental interest. So when kids meet 2 out of 4 of these criteria, along with having the social communication deficits, you meet the criteria for a diagnosis. Many times I see kids meeting 4 of those 4 criteria, so that makes things easier. So that's the DSM criteria. So this slide, I wanted to talk a little bit about what pediatricians and clinicians that work with children do for development. The way pediatric medicine is practiced has changed significantly in the last 20 years. With the development of all these vaccinations, the hospital wards are empty now. We used to, when I was a resident, I used to see a lot of patients where we were concerned about meningitis, these severe pneumonias, or other infections that would make kids really sick and sometimes could cause these kids to die. So now that is something that has been conquered with the vaccinations. Now we have, the Haemophilus influenza vaccine, the pneumococcal vaccine, and those have, it's great. It's great progress in medicine because now children are not in the hospital as much. We don't worry about those infections as much. So what pediatricians do has changed, and now pediatricians have been able to turn their sight to developmental and behavioral problems. And that has been a big transition for physicians. There are some physicians that still are not having this developmental model in their pediatric practices. But I feel the majority of them are catching up. Nowadays the residency office throughout the U.S. Mandates that all pediatric residents should spend 1 month working with a developmental behavioral pediatrician so they could learn more about these concepts. So I think that is important. So when you think about pediatricians or family practice docs that take care of children, you need to think also that they are really busy. They have to see a lot of kids. They see 20, 30 kids in their offices, and they don't have a lot of time. They oftentimes they have 15, 20 minutes, usually 15 minutes to see a child for a well-child visit. And there are so many things to talk about in the well-child visit in terms of anticipatory guidance. And sometimes, when they come to the office, the child has a medical problem, got a cold, an ear infection, has asthma, so there's not a lot of time to do a full developmental evaluation. I feel that I'm very fortunate because of what I do. I have 1 hour to spend with a new patient, but that's not something that general pediatricians can do. So, they figure out that because there was so little time left to do developmental assessments, even though pediatricians were really good, they were not picking up the kids that were delayed. So the big advancement that came up in the 90s is, okay, let's do a screening. Let's do a systematic screening to catch these kids. And that nowadays, a lot of pediatricians use these ASQs or the PEDS screening tools that, ask parents about their child's development. And then when they come to the office with the pediatrician has the data and can talk about that. And these tools are very efficacious. They catch 70 to 80% of kids that have developmental delays, but it's not perfect. There are still still parents that over-report concerns, and there are still parents that under-report concerns. And so it's not a perfect system. Ideally, clinicians that take care of young children should try to confirm if the information that was provided in the screening tool was accurate. But this is a big step forward. There are also screening tools that are specific for autism that are supposed to be implemented at 18 and 24 months of age. And there are pediatricians that are more ahead in using that than others, but overall, I think the awareness about development and about autism in the medical community has moved forward. So the early intervention system is a really important piece for pediatricians, because when they identify a child that has developmental delay, they refer children to early intervention. And I feel that the participation of clinicians still, like I mentioned before, is not perfect. There are still some, as you probably see in your day-to-day practice, there are still some that are not referring to early intervention as much as we would like to. But the majority of them are more aware of early intervention and are taking advantage of this nice program. So I would like to talk a little bit about the diagnosis of autism and just give like a kind of like a big picture. So you are often exposed to the medical diagnostic teams, and the way you diagnose autism is you want to get a good history from the parents and from clinicians that may be working, but usually, most teams get the information from parents in the evaluation. Then there's a need. It's not enough to get a history to make a diagnosis of autism. Many times I've seen families that give me a perfect history that is consistent with autism, but still I need to see the kid, and I need to confirm when I'm seeing the kid on the things that were reported by parents. And the third key piece for an autism evaluation is we need to do an assessment of the child's developmental level, so we can interpret what we see and what parents report in the context of the child's developmental level. So, in terms of the history, there are some tools that help get the history, but the majority of clinicians do, in regular practice, do their own history. I have my template that I know by heart, and I ask the same questions over and over. But for research purposes, there's this ADIR tool that is very good, but it's not really practical for clinics because it takes like a couple of hours to do. And something that you are seeing more and more is the ADOS. The ADOS is the gold standard for diagnosing autism. It's a really good tool, but requires a lot of interpretation and training. And something that you should know is that the ADOS is not perfect. I do see some kids that have a positive ADOS, that the ADOS says is consistent with autism, but then you need to see the kid not just on the test. And we sometimes we get a positive ADOS that says the kid has autism, but when we're interacting with the child and we don't feel that there's the social connectedness impairment. Sometimes that happens when kids have significant developmental delays. So we may choose not to give the diagnosis and to keep following the child. And sometimes also you may have a negative ADOS where the kid does great in the ADOS, but then you are seeing the kid and there's something that is not quite right in terms of the connectedness. And that happens more often in kids that are more verbal and have milder forms of autism. A word about the STAT. I like the STAT. It's a tool for toddlers and young children. Some people say it's an abbreviated ADOS. I don't think it's an abbreviated ADOS. It's like a much more simple tool. I don't think that there's not a lot of research on the STAT the way there's research with the ADOS. But it's a tool that helps clinicians. Particularly, I use the STAT sometimes when I have a kid that have a clear-cut presentation of autism. You know how sometimes you see a kid and this kid has autism and there's not much question about the diagnosis. But for a kid that has a milder form of autism, I think it's really critical to do an ADOS. And more the insurance companies and the schools are asking for an ADOS. And we at Rush, we try to do ADOS for all of our medical diagnostic evaluation patients because that's the way things are going. And in terms of the developmental evaluation, many times the modeling the Bailey. Those are tools that are used for young children. For older children, you want to use the WIPSI or the WISC to identify IQ. You know, those are not, the modeling is not a great tool, but it's like a very practical tool that gives you a good idea of where the child is. We also, something that is also important that is not here is the language level of the child. It's really important to assess, to put that in perspective of when you are interpreting these symptoms. A few words about treatment. So we have the early parent-mediated treatments like floor time, and then you have the naturalistic developmental behavioral interventions, ABA. I know there are some people that are big on floor time, and they don't like ABA, and there are some people that are big on ABA and say, well, there's not a lot of evidence for floor time. So the research evidence is more for the ABA because it's an intervention that is based on data. And floor time is less structured, it's more around what the children, where the children is, what the children likes, and trying to build relationships on that. And it's harder to get data. But there's data coming from floor time. Something I want to say, you know, I think ABA is a good intervention because I see ABA as a method of teaching. And I think you can teach many things to young children using ABA. The more progressive ABA therapies focus a lot on teaching social interactions, teaching communication, and it can be very effective. I think ABA has a bad reputation from the discrete trials when, you know, they would sit a kid on a table and have the kid memorizing pictures, which, you know, they were not really generalizing. So I feel ABA is a good intervention that can be very helpful. I also think floor time is a great intervention. It's based around you know, where the child is. But I think at the end of the day, the optimal intervention is something that takes from ABA and also takes from floor time. And we are seeing that more and more. There are new models coming up that are showing more evidence, like the Early Start Denver model, and we hear more recently about the joint attention, symbolic play, engagement, and regulation, the Jasper model. And those models are taken from both, from floor time and from ABA. So, and there are also interventions for school-age children, adolescents, and adults. And then for pharmacological interventions, there's no medication for autism at this time. One of the aims of increasing the understanding of the genetics of autism is try to come up with targeted brain treatments, treat autism. But, you know, we're still far from having like a product that is going to help. We're still not there. There are some trials with oxytocin, vasopressin. There are new drugs that are coming up that are showing to be promising, but we don't have a drug that has been approved. What we do with medicines, physicians that prescribe medication, is we try to address the mental health comorbidities like ADHD, anxiety, depression, which can really interfere with the function of these individuals. So I've seen, you know, some kids that have autism, when you treat, usually not kids that are in the early intervention age, but a little bit older, when you identify ADHD, mood dysregulation, or anxiety, depression, and you treat those conditions effectively, sometimes you can see a lot of improvement in the overall functioning of these children. So that's something, but it's not treating autism, but it's treating more the mental health comorbidity that is adding strain to the functioning of this child. So this is something I'd like to mention. Dr. Stephen Shore is an individual with autism, and he's a professor of special education in Rochester, in New York. And he said, if you have met one person with autism, you have met one person with autism. There's so much variability in the clinical presentation of autism. And many times I see parents that report I say my kid cannot have autism because I know this other kid that has autism, and my kid is very different from that kid. But there is so much heterogeneity in autism. And these are the variables that make the presentation different. There's the IQ, there's language, there's the severity of autism, there's the family, how the family works with this child, there's the motor skills, there's the comorbid psychiatric conditions. And, something that I see, I have the luxury of seeing kids with autism over time, and I see them grow, and I see some really nice trajectories with kids make a lot of progress. But then I also see some kids that don't have such great trajectories, and they tend to be more like even though they're growing up with a lot of services, ABA, floor time, parents very motivated, and still, some kids don't have these great trajectories. So I usually tell parents to take one day at a time, like focus on the next day, and try to do the best for the kids, and feel good that they are doing their best to help their kids move forward. So okay. So we're going to go to...
We do have a question from Kimber, and Kimber wants to know if you believe pediatricians are initially recognizing developmental delays, or is it coming from the parents bringing that concern to their attention?
This is a great question. What I'm seeing, I'm very fortunate because I see kids in the medical diagnostic evaluation, so I ask about that. How did you come here? When did you become concerned? And I hear both. I hear for some kids, the pediatrician is the one that identifies the developmental delays when they go for a well-child visit. Either the 12, 15, 18-month well-child visit, it is the pediatrician that identifies. But I also see that some parents know when something, parents often know, not always, parents often know that something is not quite right with their child. And sometimes, they bring it up to the pediatrician, and I see more and more pediatricians being responsive to the parents' concerns. Once in a while, I still hear that the pediatrician says, no, let's wait, I think your child is okay. But I see that parents many times take action, and, they may, if the pediatrician is not responsive, they may go directly to early intervention. But sometimes I also see parents that don't act when the pediatrician says, let's wait. So you get to see a little bit of everything. But I think overall, I see that pediatricians are more engaged with development, are looking more for development, and are more ready to act. As a group, I think there has been progress.
Thank you. Let's see. I don't see any other questions so far. Oh, wait a minute. There's one more. Ellen asked, how do you determine the difference between intellectual delays and autism?
That's a great question. We do measure. We use standardized tools to measure development. When you have young children, it's harder to measure IQ. But we measure cognitive function using the Bailey, the Mullen, and you can have some scores that can tell you where is the child in terms of what are the cognitive tasks that they are doing. You also measure language. Language is a nice window to cognition in young children. So kids that have good, particularly receptive language skills are a good kind of proxy to estimate cognitive function. As kids grow older, you can get more reliable measures of intellectual or cognitive functioning. But I feel until kids, when you have IQs at 3 or 5 years of age, it's still not final because children are still unfolding. I think you have more definite intellectual levels of functioning when they are more like 7 or 8 years of age.
Okay, we had a couple more questions come through, but we're going to just deal with one more this time, and then we'll catch the next one at the next break. Joanna wants to know what's the earliest age that you can diagnose autism.
So I've seen kids that have a little more than a year that were diagnosed with autism. And those are kids that really have like a classic form of autism. And I think the more severe the autism, the earlier you can diagnose it. It is harder when kids have a milder form of autism. Sometimes you suspect it, but you don't see it as clearly, so it may take a little bit longer. But nowadays, people are trying to diagnose children after they turn 12, 15 months of age, particularly if the presentation is more classic.
Okay, I think we can move forward. Thank you so much.
Okay. Thank you. So let's go more into heritability. So the big evidence that autism is heritable is there have been a series of 30 twin studies of autism that have been published, and they have looked at identical twins. So they have the same, they come from the same egg, they have the same genetic material. And for identical twins, the concordance rate of autism, so both having autism, is 70 to 90%, which tells you that this is a very heritable condition. When you look at the fraternal twins that are not identical, then the concordance rate is much lower. So those are like the lines of evidence for the heritability. Some of the most important lines of evidence for heritability. So now we have this question: what is the recurrence risk of having a second child? This is a question that I hear often from parents when we break the news. What's the risk of having a second child with autism? So can you please answer? So
go ahead and find that fourth box under your name, which is the polling function, and use that to respond to the poll. If you are using an app on your phone, we know that you don't have the poll function, and go ahead and put that answer in the chat box. But if you are sitting at your computer, please use the polling function so that we can kind of see the overall results, the overall answers. We'll give folks a few more seconds to find that fourth box under your name, open it up, and you should have the choices of A, B, C, or D. All right, we'll go ahead and post the results. So answers were pretty much across the board. Pretty much everybody ruled out A, but it's split between the rest. So what is the answer?
Well, thank you for participating. So the common understanding of the risk for having a second child with autism has been 6% for a while, but like a few years back, there was this study in the Maine Institute in California where they tracked siblings of children with siblings of kids with autism, and they were following them since birth, and they had this big cohort of all kids that were siblings of kids with autism that were tracked, and they found a prevalence of 18%, or like a recurrence risk of 18%. So the number that I tell families is 6 to 18%. That's the number that I tell families. That's the range that is currently understood for having a second child with autism. If we do genetic testing, as we're going to talk in a little bit, we may have a better sense of, if there's, we can sometimes give a more accurate or a more precise number. The CDC has 2 to 18%, and that's the number I put here as the answer. 2 to 18% is what the CDC is saying now, but I usually tell families more like 6 to 18%. And then the recurrence risk of having a third child with autism is, if you have 2 kids with autism, the risk is much higher. So what is the cause of autism? So the current understanding is that it's a multifactorial model with both genetic and environmental factors, possibly acting in combination. So 10 to 20% of individuals with autism have been found to have an identifiable genetic cause. And some of them you may have heard of, like Fragile X, Rett syndrome, and there are others that, is just like a number, like 6p1.2 microdeletion. So something that is important to mention that I said before is there's no single genetic cause that is accounting for more than 1 or 2% of the autism features. And so there are many, many genes, but there's a lot of heterogeneity. So the same variability in terms of the clinical presentation for autism, we also have a lot of variability in terms of the genetic cause. So there are, if you look at our genome, we have like 3 million genetic variants. And there are common variants and rare variants, and there are also intermediate variants. So the 95% of our genetic variants are shared with 5% of the population. So these are considered common variants. And rare variants are more unique to an individual or to their family. And so a concept that is really important to bring up that has come, something I want you to know is that there are new next generation sequencing genetic tests that are giving a lot of information about the genetics of autism. So there are like mutations that are transmitted from parents to kids, but you many times you hear when you talk with parents of a kid with autism, there's nobody in my family that has autism. I don't know why my kid got autism. And what this next generation genetic test is showing is that a lot of the kids with autism, up to 40% of kids with autism, have mutations that are not transmitted by parents. These are mutations that happen in the germinal cells. So it happens either in the sperm of the father or in the mother's egg when the embryo is forming. That's when these mutations happen. And they seem to have an important role in, like I said, up to 40% of the cases with autism. Another concept that I want to throw here is syndromic versus non-syndromic autism. So syndromic or complex autism means that these kids have dysmorphic features. Or sometimes I hear people talk about this is a funny looking kid. And if you look at the kid with a geneticist, the geneticist is going to identify these kids have low setting ears, they have the space between the eyes is wide, or they have upslanting eyes, or they have hands, the hands are different, they have small hands, or they have any defects with the fingers. So those are dysmorphic features, but something that we need to realize is only 20% of the kids with autism have these quote-unquote dysmorphic features, while the majority of kids with autism look like any other kid. They don't seem to have these dysmorphic features, and only 20% of kids have these dysmorphic features. So if you do genetic testing in the 80% that don't have dysmorphic features, the yield of finding a cause is low. So the majority of these kids we haven't been able to identify a cause for their autism, a genetic cause. But in 20%, in those 20% that have dysmorphic feature, the yield of genetic testing is much higher. Actually, half of them you will have a cause identified. So I want to talk a little bit about common variants. So common variants are relatively, I mentioned to you, like 5% of the population share these. So these are relatively high frequency genes. They happen a lot in typically developing people. And they give low but give risk for autism. But one of these low risk common variants for autism is not enough to cause autism. You may need up to 5 hits of these low risk genes to have autism. And the thing is, these autism traits are distributed in the normal general population. So all of us may have 1 or 2 of those common variants. But because they have low risk, we don't have autism. Some people may be a little more quirky, and they may have 3, and they may have a little bit of that, but it's not enough to have the full presentation of autism. But because they are in the general population, it's so hard to identify. And then we have the rare genes. There are a small group of genes that are rare, but they give a lot of risk for autism. So these are low-frequency genes responsible for high genetic risk for autism. And these can be inherited, or it can be new mutations that happen in the germinal cells of the parents. And it's hypothesized that 10 to 20% of all cases of autism are caused by these rare inherited high-risk genes. So this is a really busy picture, but I want you to focus here to have an idea of what is going on with the genetic, identifying the genetic cause for autism. Like, these are 49% of cases are these common variants that I was telling you about, that individuals with autism need to have 4 or 5 hits with these low-risk common variants, but these are so hard to identify, so 50%. In 40% of cases, we really don't know what's going on. So only in like 10% of cases, we have the rare inherited that we can identify, or identify de novo mutation. So we are still identifying only a small portion of individuals with autism for the cause, for what is the genetic cause. Even though we know the majority of cases of autism have a strong genetic factor, we can only identify this genetic factor in a small proportion of individuals with autism. So I'm going to go a little bit quick on this. So what can cause autism? It can be only one gene that explains autism, or it can be a group of genes next to each other. And the majority of cases have these low-risk genes that are common and that need more than one, like 3 or 4 or 5 hits to cause autism. So here are some examples. The best example that I can come up for a single gene disorder that causes autism is Fragile X. We do a lot of work for Fragile X at Rush with Dr. Barry Kravis. And what happens is there's one gene that codes for one protein, is the FMR1 protein. So the absence of this FMR1 protein leads to a cascade of events in the brain that cause the Fragile X syndrome that we see. These kids have often, not all, they often have intellectual disabilities, they have problems with behavior, and they oftentimes have autism. Actually, the most common, the gene defect that contributes, that has a higher prevalence to cause autism is Fragile X, because that's almost 2% of the cases with Fragile X. So there are other syndromes or genetic defects that are not just one gene, but a group of genes that are together, like what we see in Angelman syndrome and these other syndromes that I'm mentioning here. And then we also have the multifactorial, like the one I mentioned, that we have these common genes that have more than one hit, and then there are also like the environmental factors, which, for the most part, the understanding of environmental factors causing autism is very, we don't know a lot about that. There are a lot of studies going on looking for environmental factors causing autism. We know that things that happen during pregnancy, like exposure to alcohol, to drugs, to tobacco, can be factors for autism, like having exposure to substances like SSRIs has been linked with increasing the risk for autism. The events that happen at birth, if there's a complicated delivery, those are factors that can also be attributed. There's also parental age that has been associated with autism, but there are also hypotheses about pollutants or other factors that may be implicated in causing autism, but still we don't have a good understanding of that. But there's a lot of research going on in that area. So any questions at
this time? We do have a couple of questions, and so Aubrey and Josh kind of have a question that kind of goes together. So Aubrey's kind of wondering just what does heritability imply, and along with that, Josh is asking whether or not you're looking at whether both parents have a genetic history and with the risk factors increase with one parent versus both parents. Does that make sense?
So, I'm sorry, and that's, can you repeat? I didn't.
Sure. Okay. Well, I'll break it back down. Aubrey wants to know just what heritability actually implies. And
okay,
yeah, you want me to do that one first?
Yeah, heritability means that it can be transmitted through parents to kids, even if the parents don't have it.
And then Josh is wondering whether or not you're looking at both parents having a genetic history versus just one parent, and if the risk factor increases if both parents have a genetic history.
Definitely, and I'm going to talk a little more about that in a few minutes, but definitely it's important to know if parents have risk, and the more history, the higher the risk for having autism, but again, not necessarily.
And then Diane wants to know, does difficult labor impact the chances of a baby developing autism spectrum disorder?
There is some evidence pointing towards that. So it's not something, we don't know how much is that a factor, but there is some evidence showing that events in utero and during delivery in early life that can cause an insult or stress to the baby. Those have been implicated, but there's no full understanding. There are even some people that said that maybe mother stress during pregnancy could be a factor for autism, but again, these are more hypotheses and it's not been proven.
And we have a question about treatment, but I know you're going to talk a little bit about that in a bit, so I'm going to hold that one for a moment. But Monica wants to know you mentioned environmental factors, so what kind of environmental factors are suspected to having ties to autism?
So at this time, the environmental factors that are more suspected are parental age, exposure to substances in utero. Like I just mentioned, like if there's any episode like birth trauma or parental stress that has been suspected. And there are also some people that hypothesize that pollutants, toxins, substances that the mother may ingest, some of them may have a role. But again, like this is in the understanding of the role of the environment in causing autism is in its infancy. So it's very limited, what we know for sure.
Okay. The other questions I think you're going to be dealing with in the presentation, so we'll go ahead and move forward. Thank you so much for those questions, everyone. Keep them coming, and we'll move forward with the presentation. Thank you, Doctor.
Okay. So this is something that I really like. This is a novel tool that came up in 2018. It was an article that came in 2018 that is a novel tool to explain the complexity of the etiology of autism. So So this model, uses a cup, and if the cup fills up to a threshold, then the individual has autism. So what would fill the cup are the risk factors for autism. And so there are, this tries to illustrate the different factors that can cause autism. So there are like the ones that I mentioned, the common variants that have low risk, that are smaller balls, that don't fill up that cup too much. And there are the rare genetic variants that are larger and give more risk for autism. And then there are the environmental factors, which we don't know a lot about, but they are supposed to give smaller risk for autism. So we have this individual that has a couple of weaker genetic factors and has 3 environmental factors, but that doesn't fill the cup. So this individual doesn't reach the threshold and doesn't present autism. But on the other hand, we have another individual that has 3 weaker common variants, and then has 3 environmental factors like the other, but has 1 rare variant that gives a lot of risk. So this individual reaches the threshold and has autism. So let's go to the next slide. Any questions at this point?
No, we're good.
Okay. So then we have a father and a mother. They don't have autism, like many families that we see, right? Both parents don't have autism. So the father has been exposed to 3 environmental factors, small risk, and 1 common variant with a weak genetic factor. So the dad doesn't have autism. But interestingly, the mom has 1 strong risk factor for autism. This is a bigger risk factor for autism, and she also has a common variant that gives a little bit of risk and 1 environmental factor. So they have child 1, and child 1 got a couple of the common variants from parents, has similar environmental factors, but got this rare variant that gives a lot of risk. So this child reaches the threshold and has autism. And then they have child 2. But child 2 somehow only got mom's common variant, weaker risk factor, and has 1 environmental factor. So this child doesn't have autism. And child 3, interestingly, got mom's strong risk factor, but just like mom, he only got an extra common variant with low risk. So like mom, he doesn't have, even though this child 3 has this strong risk factor, didn't develop autism. But look at child 4. Child 4 has the environmental factors, has 1 common variant, weak risk factor, and this child 4 got a de novo mutation. So this is not the risk factor from mom. This individual got a new mutation that probably happened in the germinal cells of the parents. And this individual has autism. But look, this individual is going to have a different autism than child 1 because they have different genetic factors behind their autism. So they may look very different. And they have 2 siblings that are not going to have autism, but maybe child 3, she may have a little more risk to have a child with autism because she's going to keep passing this strong, she has the potential to keep passing this strong risk factor. So I'm going to move to this slide. And this slide, what this tries to illustrate is the fact that females have a higher threshold to get autism. So they have, quote unquote, a bigger cup. So they need to have more risk factors to develop autism. And something that I need to mention, if I'm talking about females and autism, the diagnosis of autism in females is much harder because they tend to present a milder presentation than males. So oftentimes, not always, but sometimes, females are identified to have autism later on. So this makes things a little more complicated, but so the concept here is and this is something I would like you to think about, is that the genes that cause autism don't just cause autism. The genes that cause autism can also cause other neurodevelopmental disorders and mental health disorders. So this gene that we're talking here, the ASTN2, is a risk factor for autism, but it's also a risk factor for OCD, and it's also a risk factor for ADHD. So the same exercise that we had for, there are common variants and rare variants that can give risk for autism, for OCD, and ADHD. And there's a lot of evidence that shows that the genes for autism, this is not in this slide, there's a lot of evidence that the genes for autism also give risk for intellectual disabilities, also give risk to seizures, to seizure disorders. So I think it's a concept that is important to keep in mind. So a lot of interesting information. I wonder if there are questions at this point.
I haven't seen any new questions that have come up related to the genetics. We have a couple of pending questions that I think you're going to get to. One has to do with treatment, specifically prescribing vitamins and supplements. And another question has to do with differentiating autism in a child that has Down syndrome. And I know that's part of your presentation. I also know we have about 15 minutes left. So I just want to put those out there and let you determine whether or not you want to answer those now or get to them later.
Yeah, I think at this time there's no vitamin that is recommended to prevent autism. Some people talk about folinic acid being a factor, but I don't think the evidence is out there to make the scientific, like the doctors, to recommend using that to prevent. I think it's important that mothers use their prenatal vitamins. I think it's important that kids take, if they don't eat, don't have a balanced diet, to supplement their diet with vitamins, but multivitamins. I don't recommend any vitamin to protect towards autism or to treat autism.
Ellen's got an add-on to that question, and what about special diets like gluten and casein-free?
I know this is kind of like a controversial topic. The evidence so far doesn't demonstrate that a casein-free, gluten-free diet really makes a difference in autism. That's the evidence that is published. I must say that I work with a lot of families, and some families claim anecdotally that doing those diets have helped their children. But I don't think it's the placebo effect when you do interventions for families with children with neurodevelopmental disabilities is really high. And so I tell families, as long as you are sure that your child is getting good nutrition and you get the support of a dietitian, I don't think there's anything wrong to try a casein-free, gluten-free diet. But if you're going to do that, try to look at some objective measures to see if this intervention is making a difference or not. So I don't discourage families to do it, but just make sure that they are safe with their child's nutrition. Okay.
And then the other question about Down syndrome, I know you're going to deal with here in just a minute, and we've got about 11 minutes left.
Yeah. I'm going to run a little bit, and maybe at the end I can answer that question. Autism is not a final medical diagnosis, because autism is more like a behavioral diagnosis. We need to order genetic testing, and that's going to give us the final diagnosis on what is causing this child's neurodevelopmental problem. And these are the recommendations this is for physicians. what do we recommend for testing? This comes from the American Academy of Genetics. We need to do a 3-generation family history to talk about risk. We need to do a detailed examination looking for those dysmorphic features. And what is recommended is doing a microarray analysis. That's the current standard of care for the diagnosis of autism. And then for males, it's recommended to check for Fragile X. Fragile X is rare, but it's probably the most important genetic cause, the single most common genetic cause that explains autism. And then we also, this is testing for Rett syndrome, particularly in kids that have these symptoms. Fragile X should also be checked in females, not just in males. It happens less frequently in females, but there are still a lot of females that have that. If the kid has a really big head, we should look for this gene. So another test that is coming available more, and that's what I was talking about, the next generation sequencing, is whole exome sequencing or genome sequencing. It's hard to get insurance. It's hard to get insurance to pay for the microarray, but it's even harder to get them to pay for these more sophisticated tests. So I'm going to jump to this. Why do we want to do genetic testing? You know, if you identify a cause for the autism, it's going to help parents, you know, okay, there's something going on, and this is what caused this problem. It can, if you identify one genetic defect, you can put that genetic defect, you can do a search, and you can look at other kids that have the same genetic test, and that can help estimate, predict the developmental trajectories of this particular child. It's going to help, you know, if you find a cause for the autism, that's going to give you a more accurate, a more precise risk for having other children with autism, or it can tell you also about the risk of your children having other children with autism. There are some genetic defects that are associated with medical vulnerabilities, so it can help monitor for those medical vulnerabilities. And sometimes having a genetic diagnosis is going to help to get more services. So here are some examples of medical vulnerabilities. So this defect in chromosome 1 in the short arm of chromosome 1 has risk for cardiac defects. So kids that get this diagnosis get an echo just to make sure they don't have a cardiac defect. Or this chromosome 17 short arm, they have more risk for diabetes. So you are going to be screening more aggressively for diabetes, and you're going to be working more on weight. And then also this defect, the long arm of chromosome 16 defect, is associated with obesity, so you're going to be working early on diet to prevent obesity. So this is the size of the genetic defects. I think this is an important concept. The old karyotype would look at the big defects. You know, this is the test that we still use to diagnose Down syndrome when there's a whole chromosome. You can just see it, because it doesn't have a big resolution. The majority of genetic defects that we see in autism are smaller, and you cannot see with the karyotype. So to see these defects, you need the microarray. But there are some genetic defects, the single gene defects that I was talking about, you cannot even see with the microarray. You have to do a specific test that looks at, you know, at the specific sequence. Like for instance, for Fragile X, the microarray doesn't tell you if a kid has Fragile X. You need to do a specific test for Fragile X. But for Angelman syndrome, which is a contiguous gene defect, then the microarray can tell you about it. So it's really important. For some conditions, the microarray works, but for some, you need to do, like, the physician needs to suspect it, and then you need to do it. I'm going to skip this. So this is a question because of time. I'm going to just skip. The question is, what's the yield of genetic testing in a child who presents with dysmorphic features? And the other question, so the yield for a kid, you know, if you do genetic testing, if I have a patient in my office that gets a new diagnosis of autism, and I order genetic testing, the yield is going to be 8 to 9%. It's not that great if the kid doesn't have these morphic features. But if the kid has these morphic features, the yield goes more to 17 to 21%. So this is the microarray. This is what they do in the microarray. They get the patient's DNA, and they compare the patient's DNA with a reference DNA. And they put it in a glass microarray slide that compares side to side, one to each other, and is going to identify areas of deletions, areas of loss, using a computer. So what the microarray is going to identify is if there's a piece of genetic material that is lost, or if there's a duplication, because that can also be a problem. So it detects mostly microdeletions and microduplications. What is not detected with the microarray, like I mentioned before with the Fragile X, small changes in the sequence of single genes, like Fragile X. So this is something that is really important. What happens when somebody gets, what are the options when somebody gets a genetic test? The result can be normal, so we didn't identify a cause for their autism, but that doesn't mean that there's no genetic cause for the autism. It means that we couldn't identify the genetic cause. We can find something that's for sure, like a pathogenic. We can identify something that for sure we can say, oh, this is what caused the autism. And sometimes we can have a finding, we have a microdeletion or a microduplication, but when you review what's the function of that gene, you can say, oh, you know, there's a microdeletion, but that doesn't mean anything. We know for sure that that's just an incidental finding. The frustrating part about the genetic testing is that when you get this, like we found something, but we don't know what does that mean. So that's what is called a variant of uncertain significance. There's a deletion or duplication, but we don't know if that's causing the autism or not. So what do we recommend in those cases? We recommend is test parents. So if you test the parents and none of them have this variant of unknown significance, then maybe this is a de novo mutation, and maybe this is what caused the problem. But if the parent has it, it's not totally clear, because it could be a normal familial variant, or it could be something that, you know, caused the autism, but in the mom it didn't cause a problem, but it's causing a problem in the child. But it gives you kind of a general idea that it's really important to get the parental testing when you don't know for sure what does the finding mean. I'm gonna jump here, and since we don't have a lot of time. So what is next? This is a busy schedule. I'm not a busy slide. I'm not going to explain this slide. What I'm trying to tell you with this slide is, you know, once you identify a genetic defect, what geneticists researchers are doing is are developing an animal model that has the same genetic defect. You can engineer an animal model like a mouse or a monkey that has the same genetic defect, and then you start experimenting with the animal model. And by experimenting with the animal model, you can understand how this genetic defect is causing all these changes that change the brain and cause the developmental behavioral differences that we see. So that's the importance of identifying the genetic cause, because that could give the path to understand the mechanism and see, once you understand the mechanisms, then you can try to come up with targeted treatments that may make a difference for these individuals. So that's what we are, so these are some of the targeted treatments that are coming up. So I had an example, what we did with Down syndrome. So what do you think, Maria? What should we do?
I think we have a couple of questions left, so I think maybe if we could just address the question that is out there, because I don't think we want to get into much more. The question is, oh my goodness, where did it go? Hang on here. Shoot, I lost it. It has to do with differentiating the diagnosis between Down syndrome and developmental delay. I'm sorry, Down syndrome and autism.
Yeah, that's a great question. Any developmental disorder, global developmental delays, Down syndrome, cerebral palsy, to say one, those are associated with a different brain development. And when you have a different brain development, that places the individual in a higher risk category to have autism. We have the concept that a lot of kids with Down syndrome are very sweet, very social, but there are some kids with Down syndrome that do have autism, and it is hard to tease out because individuals with Down syndrome tend to have some obsessive compulsive kind of behavior sometimes, and if they have severe developmental delay in their Down syndrome, it's really hard to tease out the autism. But I feel that the new classification, the DSM-5 classification, with the emphasis they put in the restricted repetitive behaviors and interests, can help define those children better. We're actually thinking about starting a clinic at Rush for doing those dual diagnosis evaluations for kids with Down syndrome that there are concerns about an autism disorder.
I know we're out of time, so for those of you who need to leave, please feel free to do so. There were just a couple other questions that I think are worth asking. Joanna wants to know about, is there any research to explain links to high prevalence in Silicon Valley or parents with high exposure to technology?
I don't have a good answer to that. I think it's interesting the CAP model and how having the high risk, the common variants with low risk that you need a few of those to have autism. But sometimes when you have the sub-threshold, like you may have 2 or 3 that don't totally give you autism, but may give you some traits for autism. I don't know. I don't have a good answer for that.
I think that probably should probably end our presentation now. We are just a few minutes over. Dr. Ochoa, I want to thank you so much for this very informative and in-depth presentation. And I know I have folks that are saying, keep going, but I also know that we scheduled this till 10:30. So we may ask you to come back and go to the next level.
I'm going to stay a little longer if there are more questions.
Yes. All right.
I can stay a little bit longer if there are more questions, but I don't know if you can.
We can stay a little bit longer, but I think folks are now starting to log off. So they found the diagram of the cup very helpful. I think that really kind of really added a nice summary of that. So with that being said, folks, I just want to remind you that you're going to be getting an email, sometime around 2-ish. Look for that. Fill out that survey, and then once that survey is completed, you'll get your certificate in the next 24 hours after that. If you have any issues, contact us at the EI training program at eitraining@illinois.edu. And I want to thank you so much for your participation, and we will talk with Doctor about maybe doing a follow-up to this at a later time. So thank you so much.
Thank you, Maria.